thanks in particular to Dr. Shanta. I'm hoping we'll see her in a minute. Dr. Kannan from Silchar, Assam, and Dr. Pramesh, who is a pro in webinars, I believe, for agreeing to speak at today's first webinar of the Indian Cancer Society and the Cancer Cure Fund. Each year, we have a conference of doctors and the medical social workers of the empaneled hospitals of the Cancer Cure Fund to share experiences and get new insights into how we can improve the way we work in CCF. Today, we have the opportunity of converting this annual conference into a virtual conference. And as against the 30-odd people who normally are able to attend this seminar, today we've had the benefit of many, many more doctors, many more social workers and other staff at the empaneled hospitals. And I think this is one of the outcomes of COVID, to realize how technology has enabled us to really increase the outreach of and access to people for attending such seminars and conferences. So today we have almost 200 participants from the empaneled hospitals, in addition to the members of the doctors and the medical social workers, in addition to members of the Board of Trustees of the Indian Cancer Society, the National Managing Committee of the Indian Cancer Society, the members of the Governing Advisory Council of the Cancer Cure Fund, both some former members, I can see Homi Kushukan, and present members. So, and also the DDT doctors, to of course, they are really the pillars of this Indian Cancer Society, Cancer Cure Fund, and the staff of the ICS, as also some of the representatives of the donors. So we have all of us here. And in particular, like I said, I would really like to thank the DDT doctors who are who have really supported this entire scheme, led by originally Dr. Banavali. I don't know whether he has logged in, and now admirably led by Dr. Tushar Vora. He's there, you can see him. Put up your hand. And we have doctors from not only the Tata Memorial Hospital, but also from the Bengaluru hospitals, and a very big thanks to Dr. Harimenan and Vijay Sharma for helping us to get the DDT in Bangalore going. So COVID has stopped many people in our tracks, but not us. And today you might have seen a front page story on the Times of India, which said that TMH had done 494 surgeries during this period, and the hospital's efforts are being printed in the annals of surgery. Similar is the experience, I'm told, by Jyotsna in the Rajiv Gandhi Cancer Institute, and I'm sure in many of your hospitals as well. Indian Cancer Society, the Cancer Cure Fund, has also been equally active during COVID times, and we have tried to not allow COVID to stop us. And although definitely the number of applications have come down, we have still approved cases, 445 cases, and committed funds for the cost of their treatment. We do realize it's an enormous challenge that we are all going through during these times, and how difficult it must be for each one of you to ensure that cancer patients receive the treatment and really help them fight in their, in their fight against cancer. Before I request Mr. Harimundra to sort of say his opening remarks, just a few housekeeping points. We have actually, like you realize, muted all the participants except the main three speakers and few of us. So then when we request you to speak, we will be unmuting you. And if you happen to have muted yourself, I would request you to unmute yourself. You can type your questions into the chat room just at the bottom of the screen. So all the questions and any comments that if you want to make a comment, then you can say that as well. So then we could, specifically request you to ask your question or get your questions answered. So we are not able to see everybody at the same time. So I would really request you to make full use of the chat room as much as you can, and feel free to, put your questions into that, and we'll try our best. It's a first for us, and I hope we are all able to go through this. So Mr. Harimundra.
Oh, thank you, Usha. It's a great occasion. Let me first say that dear Dr. Kannan, Dr. Shanta, and Dr. Pramesh, our three panelists who have agreed to come and join us, as well as all the friends which Usha recounted. Welcome to this first webinar of ICS CCF. It is a momentous year, not because of COVID, but because it is the 10th year of ICS CCF. And indeed is a great milestone during which the disbursement for patients, poor patients, have gone up 10 times. It was 3 crores in the first year, and now it is 30 crore, something which we had never even dreamt of when we launched this scheme in 2010. So there was time to celebrate, but also to take a pause during the COVID times to assess where we go from here. But before I talk about the origin and successful journey of CCF within ICS, let me talk about ICS itself first. And whenever we talk about diseases, and that is something which we keep doing about cancer, we discuss the science of epidemiology, and that is what is the origin and progress of diseases. So it set me thinking as to what is the opposite of epidemiology. How do you trace health? How do you track health? What do you call it? What is the opposite of epidemiology? How do you investigate the origin of health? So maybe, I don't know what it is called, but maybe healthfulness, perhaps maybe the word which is closest to the opposite of epidemiology, the search for health and disease management. So ICS has been a 70-year-old pioneer in the field of healthfulness against cancer, always thinking out of the box, always thinking ahead of the times, and being innovative as much as possible. So I wanted to give you a few examples of what ICS has been able to do in the last 70 years, fairly unique from the time Dr. Jasawala set it up. So it set up the first cytology and chemotherapy units in 1955 and 56. The doctors today may not know about it, but chemotherapy was not a recognized method of treating cancer in those days. Indeed, it was surgery. And when chemotherapy unit was set up by Dr. Jasawala in ICS, within ICS, because Tata Memorial was not looking at it as a viable method of treatment, there used to be a morning joke, which was that doctors would ask Dr. Jasawala, so what is the poison you are delivering today to the patients? Because obviously the side effects of some of the chemotherapy chemicals were really, really very bad. So that is how it was in those days. It was really ICS which started the first cytology and chemotherapy units in the country. It also set up the first screening and rehab centers, 1961 and 1979. It also set up the first private cancer registry and cancer journal, both in 1963. Then it set up the survivorship program, which is UGAM 2009 for childhood cancer, and Project Picasso in 2016. All of it the first. And then you will not know perhaps, but we have promoted 2 cancer hospitals. Rajiv Gandhi Hospital actually was promoted by Indian Cancer Society, Delhi branch. And then last year we promoted the HCG ICS Khubchandani Hospital at Cooperage. So we have promoted 2 hospitals which work independently. And then we have surprisingly given birth to 2 NGOs, cancer NGOs. One is in 2004, it's called Can Kids in Delhi. And again, another honorary George Secretary of ours, Harmala Gupta, set up in 1996 Can Support. So we have even given rise to 2 NGOs. And then we have initiated some modern work, technology work in the cancer awareness program. Delhi branch launched the mobile app called M Shakti. And then they followed up with an e-learning course, which has just been launched with 3,000 students who have enrolled. It's a fantastic job. And we, in this year, last year and this year, have done a fantastic awareness program across the country in both mass media and social media, the first of its kind, thanks to people like Mr. Naveen Kshatriya. So we have had many firsts to our credit, and we are justifiably proud of what ICS legacy has been. And last but not the least has been the launch of the first mutual fund, which was launched along with SDFC. Actually, it was SDFC who launched it, along with ICS, the first mutual fund to garner resources and funding for poor cancer patients in 2011. So this brings me to the story of ICS and CCF, the origin of ICS and CCF. And I'm going to bore you a little bit on this because I can be called as one of the co-architects of this scheme. So a little bit of self-praise will also come through. So actually in 2007, you will be surprised, ICS was about to die. And indeed, Dr. Arun Kurkure, who was the managing trustee at that time, did not know how to handle the financial crisis which had overwhelmed ICS. So he got from his corporate circle several friends to join ICS managing committee. And two of them was Nihal Kavretne and of course myself. And he was hoping that between some of us, we will try and put the house in order. And the first priority of ICS at that time was to survive, to actually remain alive and kicking. So it took about 3 years for us to really put it in some shape and some order. And then in 2010, Arun started asking, can we do something more? And being a doctor, being an oncologist, oncosurgeon, he was very conscious of the fact that many cancer patients are not able to get treatment because of lack of funds. In fact, he used to say quite famously that in fact cancer treatment brings many well-to-do people also below the poverty line. So people who are already poor, what happens to them? And he asked us whether there's something which we can do. Initially, it sounded very, very ambitious because we ourselves were not able to get enough donations and funds for our normal activities of awareness, detection, etc. What to talk about funding, which would mean 3 to 4 lakh rupees per patient. So 100 patients means we are talking about some 3 crores of rupees. So, but this is when we did some brainstorming between Nihal, myself, Smita Agarwal, who was at that time with us. And we thought of whether we can actually take the mutual fund route to increase the reach and depth of donation gathering. And I did some structuring of this. Smita did some investigation across the world, and we found that most of the models of mutual fund for in NGO space was where the principal would never come back to the donor. So the whoever invests in the bonds, the money will not come back forever. So it is like a perpetual bond, which today you have heard of. Now that was not going to work for ICS. So what I did was to structure it in a slightly different manner, taking into account the fact that there was Section 80G benefit, there was regulatory environment, to try and see whether we can create a debt fund where the interest only gets converted into a donation to ICS for treatment of cancer patients. The principal goes back to the original investor. And there was a fateful day, 15 January 2010, when Nihal and I brought together many fund managers, many private wealth managers, and I presented that idea to them. And really it was fantastic. Well, there was enthusiastic response to all of it, but one person who came forward at that time to bring the commitment on the table was Mr. Milind Barve. Now, he's unfortunately not being able to join this conference today, but he from HDFC AMC, he's the managing director of AMC HDFC. He said, look, I think I'm going to do something about it and help you in this because hope, he said, alone cannot fight cancer. You need money as well. And once he agreed, HDFC AMC worked out a lot of details of the fund. It would be a 3-year capital protection debt fund where investor will have the choice of contributing 50% or 100% of their dividend to ICS for cancer treatment, and principal will be returned at the end of 3 years. There will be a TG benefit which will be available. And therefore, this is the way we will combine what I would call the private capital with social capital. The fund had to have a name. And both HDFC and we thought that for the purpose of positioning this fund, we have to bring in cancer somewhere in the title. So we said, let it be HDFC Debt Fund for Cancer Cure. Now, SEBI had never heard of a fund which has a benefit attached to the name. There was a structure of investment, but not the benefit. And again, I was very lucky at that time because Mr. C.B. Bhave was the SEBI chairman. And he heard of this story and he said, okay, I will allow this name to be attached to the fund. And since then, it is called the HDFC Debt Fund for Cancer Cure. You will never find any other fund which has been named in terms of the benefit it gives. And that was the positioning of this Cancer Cure Fund. What I would also like to say is that SDFC, and especially Mr. Barve, went out of the way. He became the personal champion, spokesman of this fund. He went door to door from a lot of HNIs, a lot of corporates to garner the resources after the fund was launched. And he waived, SDFC, AMC waived all marketing expenses, all commissions. They incurred all of that in there. And that's a true service which they have done to India, really speaking. So we launched it in 2011, and thanks to his efforts, and I think the combination of both ICS protocol, which we had put down, the corporate governance, we really got something like 90 crores of rupees of funds. Now, one of the other credible party we got at that time was Tata Memorial, because as Usha was saying, we have a fantastic team of due diligence team and governing council. And it is the due diligence team which came from Tata, which was lent to us by Tata without any fees, any charges. And thanks to this team, we brought Tata name also into the picture. So we had these three credible forces, Tata Memorial Hospital, HDFC, MC, and ICS together, who have now taken this fund. It has already finished its third version. 2011 to 14, 14 to 17, and 17 to 20. And indeed, it has been a unique fundraiser ever attempted and succeeded in the history of India. I want to thank everybody who has contributed to it. And it has come a long way from then. You know, under the leadership of Usha and Naveen Kshatriya, the fund has expanded beyond HDFC. There are other donors who have come in, large donors, SBI, and BPCL in particular. And as a result, we are talking about disbursement of 30 crores of rupees per year. Cumulatively, we have given benefit to about 8,000 people, 8,000 poor patients. So where do we go from here? We go from here in three ways. I think first is we are back to 2007, the survival of the fund, survival of Cancer Cure Fund. Because we have to maintain the momentum under COVID, because a lot of CSR donations are dying up. We don't know how they will all flow in, whether we can actually launch a debt fund again under the auspices of HDFC or not. All of it are question marks. So our first priority is really to keep the momentum of the Cure, ICS, CCS, CCF. Second is the modernization in terms of technical terms of the entire exercise of taking on boarding the patients and looking after them. There's a lot of work which Usha has been working on, both in terms of artificial intelligence as well as web-based application. So can we reduce the turnaround time of the patients? Because sometimes it can take 2 months before the patient actually gets any funds released from us. We need to really work. In fact, we have a small side fund, which is the diagnostic fund, which we provide to people before they get the treatment fund. But that is not sufficient, so we have to reduce the turnaround time. And that is the second way in which we want to go forward. And third is whether we can tap some of the unexplored areas in India, poorer areas, Orissa, West Bengal, and Madhya Pradesh. We have 16 hospitals, but we don't cover India as a whole. And that is the third way in which we want to go ahead. So it's a fantastic job done. 1 decade has been a great decade of achievement, but surprisingly, we are now facing a serious crisis of COVID funds. And I think Usha is absolutely well equipped to take it forward. So may I hand over the mic to Usha now?
Thank you. Thank you so much, Hari. You've really brought to memory those days when this fund was launched. I'd just like to add one more point to what Hari said. Another unique feature was that HDFC AMC matched every rupee of the dividend which was received from the investor with their own CSR. So 15 crores of dividend annual, if that was the annual receipts, then HDFC AMC matched it 100% by 15 crores. In fact, some people said they'd like to donate to HDFC AMC Cancer Cure Fund because they knew that if they donated, then HDFC AMC is going to put 100% matching from its CSR. So I think that was also another very unique feature of this fund.
Yeah, you're
so
right.
Without, thank you very much, Hari, indeed. And thank you all. Without much ado, so now may I request Dr. Shanta from Cancer Institute, Chennai, to please talk to us as to how they are dealing with the challenge of cancer treatment during these difficult COVID times. Dr. Shanta, you'll have to unmute yourself. Yeah.
At the outset, I should give my sincere thanks to the organizers of this meeting, Madam Musha Toret, Chair, General Advisory Committee, Colonel Khader, members of the Indian Cancer Society, Cancer Cure Fund, and other invitees and beneficiaries for the opportunity to share a few thoughts on challenges of cancer treatment during COVID. I mean, I didn't know the background of Cancer Cure and the Indian Cancer Society, from where we were getting a lot of contributions. And I want to say the Cancer Institute has been a beneficiary of these great organizations, Indian Cancer Society and the Cancer Care Fund, and cannot be adequately grateful for this support. Over the last 8 years, between 2012 to 2020, out of 998 pediatric beneficiaries, over the last 8 years, between 2012 to 2020, out of 998 pediatric beneficiaries, 905 are alive and well. I think it is a great achievement. And I think I have to tell you once again, the Institute is one major institution in the country that has a lifetime follow-up of all patients treated. I think that has been our unique achievement, because I think it is mandatory to know what is happening to the treatment that we are giving. We should not go off saying that cancer is like that. We can cure cancer. That is what we want to say. I, of course, represent a non-government, voluntary, charitable cancer institution committed to care of the underprivileged with a track record of over 6 decades. Our ethos, no patient to be turned off for lack of money. The journey has been long, happy, unhappy, painful, bitter, frustrating, at the same time fulfilling. There have been many challenges, but not like the present one that we are going through. Cancer and the challenges of cancer treatment during the pandemic has affected many groups of people. It has affected all walks of life. And to start with the patient, next. The patient has the first, to face the problem. The patient has the added panic and fear. There's lack of public transport and inability to reach the treatment center. There's a delay in treatment, which is inevitable. It increases cost and increasing the need of psychological support. I think that is the most difficult thing that the patient has to face. We have the dilemma of the oncologist, because in the panic, they did not know what to do. Rather, we did not know what to do. To treat or not to treat. Is it right or wrong? How long can we defer treatment? The decision is neither simple nor easy. We have to think of the patient and the family in the context of the pandemic. Early common cancers are curable. It will be unethical to delay treatment. Advanced disease can be controlled, and if untreated, will end up and progress to a stage of palliation. Palliative care cannot be denied. common cancers with a doubtful outlook. Advanced age, multiple comorbidities form a category by themselves. They have to be treated on an individual decision and are ideally deferred. Maintaining a good doctor-patient relationship is mandatory. Can it continue? Maintaining social distance, inability to watch the facial expression, which will not be possible at that distance, will compromise on doctor patients. How long can we do this? Is it going to continue? I think, as Hippocrates said, I think it is very necessary for us to listen to the patient. And is it possible to do it at a distance? These are things that we need to think of in managing patients in the pandemic. The pandemic lockdown effect on the Cancer Institute, on a non-government institution. I think I'll have to say a few words about the institute a little later. Starting from March, the lockdown said no transport, patients started dwindling. And once the patients started dwindling, our income goes down. We are a voluntary institution. Our main income is the hospital income, from which we have to do all these services that we are doing. Now the management, the lack of transport, staff of patients. We have to not only take care of the patients because they are not coming. We have to see the staff. Staff have to be given transport because they are not able to come to the hospital. Then we had to do designing a separate entry for the outpatient and inpatient because the incidence of the virus was very high in Chennai, and we had to see in the wards, the beds have to be changed to 4 feet, and where we had 60 beds, we can have only 40 beds. So enforcing the guidelines of the COVID prevention and protection caused a great deal of difficulty and necessitating change in our methods of treatment. Precision PPE was mandatory and guideline to be given to every person dealing with patients because we do not know who is positive, who is negative. The next one. Now, if you see the practice today, therefore, we need to have a triage of examination. The patients are examined and made sure that they are possibly free from any infection. Then they go to the oncologist, where every one of them is provided with a PPE, and then they are taken for treatment. But once the investigation is over, and then the patient is ready for acceptance for treatment, either it can be radiation, surgery, or chemotherapy, or a combination of the three, we will have to make sure they are negative. So we insist that the patient has to be negative before we accept them for treatment. We've learned badly by not doing it. We've had 1 or 2 cases becoming positive, and therefore we had to do a lot of close down. So once they are negative, the respective treatment is started. The radiotherapy, we insist that the patients must be inpatient. We do not accept outpatient treatment for the simple reason Madras, Chennai is a high-risk area. Patients going up and down are likely more possible to get infected again. So it is mandatory that they are inpatient. The medical oncology follows, every department has their own SOP, that is standard operative procedures, and they follow it. So guidelines are followed strictly, and therefore we are able to continue. Surgery, of course, continues. Then again, as I said, surgery continues with doctors wearing the PPE. They say it is not very comfortable. Many a time they say the duration of surgery increases, where they can do 4 surgeries, they are able to do 2 because all the preparations that have got to be done to take protection. Now, medical, the another major problem that we are facing now is, as per the guidelines for protection, as per the guidelines to ensure that the doctors and nurses are protected, they are permitted to work only 50%. So they are work for 1 week and 1 week they are off. It's all right for hospitals, government hospitals and institutions where they have large volume of staff. In an institution like ours, where we have limited staff, I think it's going to be extremely difficult. Right at the moment, we have limited patients, and when we have limited patients, I think it is all right. But as we go on, I think it is going to be very, very difficult. Now, if you see the OP census in March, how much it was over 10,000. How is it dropped in April and May? It goes down to 2,000 and odd and 2,000, and now between April, May and June, the pickup is very, very slow. It is picking up, but it is very slow because still till yesterday there was no public transport. So I hope it will be better. But then inter-district, state transport is still lacking. Now, having said it, now the problems mainly faced because the ground reality, what I would like to say is that the Cancer Institute is an accepted major comprehensive cancer institute in India, one of the senior most, and acclaimed as one of the best. And we have many, many firsts to our credit. This is not the time for me to enlarge on it. I think it is the only NGO, non-government organization. All other cancer giving organizations are government, either central or state government, corporates or private. It makes a lot of difference. And I think the government, non-government divide has been a major obstacle and major challenge to our progress. And if we have progress in spite of it, I think it is essentially our motivation and dedication. We as a voluntary service organization committed to the care of underprivileged have only 40% of our patients are paying. We have 550 beds, out of which 100 beds are paying beds. Now we are just increasing, and then we thought we will be better off when the pandemic came, so we have not been able to increase it. Only 40% they are paying patients, and 40% are totally free, and another 30% are pay a highly nominal payment. There has been no revision of rates, which normally every corporate, every hospital does. Over the last 4 years, we have not changed the rates at all. Our rates are extremely acceptable in a sense. A single room with an air condition, what we call a class room, pays only 3,000 rupees. I think nobody can get it. And the C-class ward, which is a very, very affordable, costs about, of course we have 4 patients in the room, it is about 1,800, 1,500 to 1,800 rupees. So our costs are extremely affordable, and we have the problem because we are affordable. Many people who undergo treatment in big corporates and spend lakhs of money, and then they are not able to spend anything more, land up here and say, please treat us. I think humanity requires that we accept them. So we are loaded with a lot of these type of patients. So because we believe all the time that we are here to treat. If we are not here, who is going to treat them? So I think that is a major problem. The institute comprises of a hospital of 550 beds committed to cancer care. Of the total beds, I already said only 40% are paying. The remaining are either totally free or highly subsidized. We do have a research section. We have not been able to concentrate so much on research section because it is a very expensive thing. But we do have a good research department, which is designated a section of Center of Excellence with the Department of Science and Technology in 2007. But the priority has been clinical care. But we have we have very good people, staff, where we can do much more if there is adequate funding. We created the first College of Oncologic Sciences. There was no oncology as a specialty. The institute created it for the first time, and it was nearly 10 years later that other institutions started. And I think it will be necessary for all oncologists in India to pay a tribute to Dr. Muthulakshmi Reddy and Dr. Krishnamurthy, who were the visionaries who made it possible. Of course, I've had a small part to play in that too. Now we have a large preventive oncology division because we believe the thrust today is prevention. Prevention, early detection is the thrust for the day. And we have the preventive oncology division consists of the demographic registries, probably one of the best in the country, a hospital registry which is very unique, having the lifetime survival of patients, and cancer education and screening and tobacco control, and a cancer support group. We have 5 screening centers that are functioning in different districts of Tamil Nadu. Now, I'm highlighting all this to say that we are not only doing cancer care, clinical care, which is free, but all these are sponsored. We try as much as possible to get support and do this important thing under sponsoring. We have a palliative care center with 50 beds. We have a dharmashala. So every one of these are sponsored, and these are areas that we do not ask for funding. Now, because we have sponsors, we have long-term sponsors, and I'm just highlighting it to highlight the volume of services and activities provided by the institute. Of all the institutions that I have mentioned, the one hospital is the only earning component. There is no other earning component. The other earning component is the motivation and dedication that we go and pray for donations and do it, and very strict expenditure control so that we do not unnecessarily spend. Our staff are paid very, very nominally, in the sense that they don't get the salaries of the governments nor the corporates. The hospital income takes care of staff of the hospital services, doctors, nurses, technicians, and all supportive departments. The staff strength is 982. And at this point of time, it has been a great challenge for me because I've been with the institute for the last 60 years. And it is impossible to say we can either retrench or reduce salaries. So we have to continue the salaries. How are we going to do it is something that I do not know. And of course, we do approach all agencies, and that is why I am here. And Mrs. Usha Thorat, the Indian Cancer Society, Cancer Cure Fund, and many others know us very well, because I always say, I go with a begging bowl and say, Bhavati Bhiksham Dehi. So we have survived because of that. Now, to tell you the actuals, I think I don't want to take too much time. To tell you the actuals, the hospital income has dwindled to less than 10% as of April 1st, as of March end of April 1st. And it is coming back very, very slowly. And I do hope and I believe with our dedication and taking care, something more will come, but I'm not sure we can go back to the normal for some more time. We are continuing our efforts. Public support in kind is available, but donations are not enough, because they do come, but they don't come to the level that we look for. We have not only to look after our patients, but our staff. And I've already told you the staff strength. Anti-cancer drugs, as everybody knows, is very expensive. Probably this year it may be slightly lower because I do not know the number of patients that we have to treat. We need to provide transport for many staff members. At present, 14 vehicles pick up around 135 staff. We may need more. There are innumerable more problems. It is difficult to draw conclusions now. We need to watch month-wise. Beyond this, we have to start thinking of the future. But before I conclude, a few thoughts, my premonitions about the future of cancer care. I'm not talking of Cancer Institute. I'm talking of cancer care, because that is the care that is going to suffer. And I think we are going to be responsible to see that it does not. In general, over the last few decades, the human touch in Medicare has been dwindling, a result of increasing dependence on technology. The patient has become invisible. The pandemic has imposed changes and necessities that will definitely change our style of functioning, including treatment. We cannot predict how it will impact on the long-term results. As I've been saying, globally, I think this year cancer mortality is going to be much higher than it was earlier. Cancer management can never be and never will be the ideal as before the pandemic, because there will always be a compromise in treatment for some reason or other. The treatment cost will increase. The ultimate victim will be the underprivileged. The Cancer Institute, with its unchanging ethos, has to prepare for the future. We hope the government and the NGO divide will have a fruitful solution, because there are multiple divides for no reason. We are doing the same work that the government is doing, free service, but we are differentiated. So I think that we'll have to look, see that something is done towards it, because I'm not sure how long I will be in the scene, but I think we expect the people who are here listening to me will take care of that. We look forward to the Indian Cancer Society, Cancer Cure Front, all the related organizations and great people who have thought about it much earlier, to continue their magnanimous services in helping institutions, and so that we can, the other institutions can continue. The struggle against cancer will continue till unless we are able to get rid of the coronavirus. Thank you for the opportunity.
Thank you so much, Dr. Shanta. Could I now request Dr. Kannan to please talk about his experiences in dealing with this cancer treatment during COVID times. Dr. Kannan? And is Dr. Kannan there?
Yeah, he's there, but you have to unmute me. Oh, yeah.
Yes,
okay.
he's there.
Thank you.
Yeah, please.
Yeah,
we can hear you, see you.
Right, thank you. I want to take this opportunity to thank the Indian Cancer Society for all the support that they have given us over the last few years. And I have to make a comment that the biggest help for us has been from the Dr. Arun Kurkure Initial Evaluation Fund. You know, that is one of the biggest hurdles that we used to face in the initial evaluation. Now, I know a lot of things are happening all over the country, and you know, there's turmoil. And as my mentor, Dr. Shanta, mentioned, we have none of us is likely to see a problem as humongous as what we are all facing right now across the globe. In the Northeast, we have some peculiarities which are on one side an advantage in a pandemic like this, and in some sense disadvantages also. So we are a rural, semi-urban setting, limited resources. Most of our patients hail from our region, from the Barak Valley and neighboring states. And the pandemic here is mainly through people returning, migrants, who've been working all over the country, who are now coming back. And that is the reason for that. When the country was in lockdown initially in the first and second phases, we didn't have even though we had the dubious distinction of having the first COVID patient in the entire Northeast, a cancer patient from our hospital. The number of cases have not really gone up till the migrants have started coming back. But even now, because we have a low population density, except for in the major cities, there's a real possibility for containment of the virus. But then we have an extremely poor socio-economic status of the patients. Most of them are daily wage earners. And so in a lockdown situation, they suffer enormously. Their education levels are low. And then because of the lockdown, there are logistics of travel. And now the monsoons have set in, and it is simply pouring. There's a huge storm, going outside as we are talking. And that poses, its own set of problems in a pandemic situation like this. Initially, when this problem started off sometime in February, we had several meetings with our staff, and we had one final major meeting, face-to-face meeting with everybody present, where we explained the nature of the pandemic. We explained the fact we've been doing that again and again, to our staff about the need to be careful for their own selves, but yet to ensure courteous and compassionate care to all patients coming in. In situations like these, when everybody is stressed and fearful, often we become unkind to our own fellow human beings. And unless we take precautions, unless we take care, we sometimes will behave in less than human ways. So we try and ensure that we are compassionate all the time with every one of our patients. And we have an added responsibility. We are the only cancer hospital in the entire southern part of Assam, catering to about 50-60 lakh population. And so at all costs, we need to keep the hospital safe and functioning. And so with these three objectives in mind, we spoke about how to ensure personal safety. And then together as a group, we planned about personal prophylaxis, about social distancing, how we are going to manage hand hygiene, how we're going to put place various mechanisms in the hospital. And we created a WhatsApp group and a COVID action team. In that meeting, we also discussed about the finances. We anticipated that the finances of the hospital would go down, and which would directly impact on our ability to pay for salaries. And we actually took a joint decision in the hospital as to how we would handle it if it had to come to a situation of reducing salaries. We took a final call that initially it will be proportionately reduced, and finally when our incomes drop below a critical level, all of us from top to bottom will take home about 7,000 rupees or 7,500 rupees per month, because that is the basic salary in the hospital. And so we spoke to the staff that this reduction would be taken as a loan, and when conditions improve, we would repay the staff whatever income was cut. Now, those days, in the beginning, PPEs were in extremely short supply, and it used to cost enormous amounts. Gloves, which were 1 rupee 50 paise, suddenly went up to 9 rupees. Alcohol, which was used to make hand rub solutions, suddenly the cost shot up. And so the staff of our hospital took responsibility in making. We designed 4-layer masks with cotton and polyester in between. The staff of our preventive oncology nurses, we had to stop preventive oncology home visits, and so they took responsibility for stitching scrubs for the hospital staff. One of my colleagues, our radiation physicist, designed a facial shield, and he manufactured facial shields for the entire hospital. Our pharmacists, they took responsibility for mixing hand wash solutions. He procured alcohol from different sources, mixture of 70% alcohol with, and prepared hand wash solutions. And this is a picture that I want to share. It came to me serendipitously today. I actually was looking for some photographs in Sita, my wife's phone, and I found this. And I learned that these are masks stitched by our nurses and there was some problem. And so because these were for distribution to patients, our staff stitch masks, which are used both by the hospital staff and by patients and their caregivers. And so before distributing it to patients, the nurses sat and washed them and hung them out to dry. I don't think I could have been blessed with, staff with greater commitment, anywhere. And then we had to ensure safety processes to be put in the hospital. And we, several measures, the hospital is actually easy place. It's a community hospital where, rules are not very strict. Patients have easy access to the hospital, staff have easy access, patients' families come. It's not a conventional, strict, rule ridden hospital. Suddenly, we had to put in place a whole lot of rules. We said that every patient will be accompanied by only one single attendant, and that the attendant would have to stay in the hospital continuously for 6 days, not go in and go out. And that all patients, like what Dr. Shanta said, everybody on radiation therapy has to stay within the hospital facility. We put up washing stations all over the place with soap, and we were insisting that people wash. And then we had to create additional space. Our OPDs are very small and cramped. And suddenly we had to create an expansive OPD space outside where we had to get patients to sit. And we were insisting on masks all over the place. We put in place a mechanism where follow-ups were protracted. And then we created a triaging system at the beginning of the OPD. Then the rain, and then we were actually trying to put up a triaging center, a room with a medical facility. Then because of the rains, we had a landfall, and that whole wall slipped off. The access road to the hospital was partly damaged, and the building itself, is at risk. And we are now, hurriedly trying to create a retention wall to save both the land and the road and the hospital building. And so, all this creates a lot of inconvenience for patients. Patients feel cut up. Suddenly, there's a situation where we say, no, people cannot come into the hospital. You have to follow these rules. You cannot leave the hospital. And they are bewildered by the whole thing. So our preventive oncology nurses started, educating patients on safety measures, as well as the fact as to why we were doing all of this. Why is it that, the hospital has suddenly become, come up with so many rules? And so they do this with every shift, in the morning, in the afternoon, in the evening, in the OPDs, everywhere. And so that, patients are, comforted by the knowledge of what is happening. We also had to see, our place is far flung. The patients come from far off, and oft times travel is a major issue. Sometimes to travel 60 kilometers, patients end up spending anywhere between 2,000 and 5,000 rupees in the current environment. And so we are not able to ask them to come on several visits. So now we have to ensure that the day they come into the hospital, everything is finished. They go back with a diagnosis, stage, and a treatment plan. Earlier, we were trying to do this in 1 or 2 days. But now patient comes the same day in the afternoon, we do the endoscopy, same day we do the staging CT scan, we do the biopsy, we use frozen section reporting. And by the time the patient goes back because he must have value for what he has spent, and he cannot come back again for other investigations. The other department, the home care problem, team has been the worst affected, because we are not able to make home visits now. So every single patient is contacted on we've gotten used to making video calls on WhatsApp, so, and there are tele rounds now. We have a nurse who sits in the morning and calls every single patient at home, talks to them, and sees what's happening. Opioid availability became a major issue during the peak of the lockdown. And so we called everybody and found out people who were not having opioids, because medical personnel could travel. And also patients sometimes with passes were able to travel. We were able to reach opioids to everybody who needed them. And when we did an audit toward the end of April, several patients had died during the lockdown at home of advanced cancer, but nobody complained for want of opioids. Access to chemotherapy was another problem. People who were having oral chemotherapy on imatinib, or we were giving them supplies for 3 months and 4 months at a time, and we were following them up at home. We were also trying to, these facilities 108 and 104 are available with the government, and many patients are not aware of it. And we sort of encourage patients to use these facilities in order to come to the hospital and in order to access drugs made available at home. And in the 3 months of the lockdown, we saw about 750 patients, and our medical, surgical, radiation oncology, surgical procedures went on. So all of them, in terms of absolute numbers, have come down. We are an integral part of the community here, and therefore we have to take the leadership in engaging with the community in these times to educate them about the impact of the pandemic on their daily life. There's a lot of fear, even though the numbers in the region are not so many, but the fear factor compounds the whole problem many times. And so along with the district administration, we used social media and print media in a very large way. We do web conferencing almost every day, morning, afternoon, with different groups at different times, telling them about the pandemic, about the ways of social distancing, mask wearing, hand washing, in order to delay spread of infection from one individual. Because in our area, in the northeast, in the Borak Valley, it's a really feasible thing for us if the community gets together. In the Borak Valley, we don't even have 300 positive individuals at the moment, and so there's a real opportunity for us to contain the disease. And so we engage with a whole lot of social organizations, with the Anganwadi workers, with the ASHA workers. And so that happens every day, in the morning, in the afternoon, in the evening. And in return, we've had tremendous support from the community. When we sent out word saying that we needed cloth for making masks, we had bales and bales of cloth delivered at our doorstep. People came and gave us sewing machines. They gave us hand washers. And now, we started with one sewing machine. We have several of them in the hospital now. And that's an opportunity for us to rehabilitate caregivers of patients. See, many of our patients are daily wage earners, and often there is a single earning member. And if that member dies of cancer, the family is often on the streets. And so we have a program wherein every patient with advanced cancer, we try and get hold of one of the caregivers and teach him or her some life skills, that will help them sustain the family after the breadwinner passes away. And so now one of the opportunities we've had several sewing machines donated to us. And now we are now starting a center to teach women or even men, to sew, so that they will be able to take care of their own livelihoods later on. We've had support. Now we want to put up an expansion for accommodating more patients in the outpatient area. We had people give us sand and a whole lot of things. And so I think this pandemic has provided a major hurdle in cancer care. We are all facing it, but in its own way, it has also provided us opportunities to bring out the best in human beings, in order to be more compassionate, in order to use these opportunities to help one another in innovative ways, if I can use the word. And ultimately, I think all of us will come out stronger because of what we have experienced jointly, as opposed to single individuals experiencing hurdles. Thank you very much.
What probably COVID has brought is how humanity is again activated in human beings. May I now request Dr. Pramesh to share his experiences and also probably share something about how we should prepare ourselves for the times ahead, which also implies that we know how long this is going to be, and that's one uncertain area we really don't know. So what is it? What are your thoughts on how hospitals should really prepare for themselves for the days ahead? Dr. Pramesh.
Thank you very much, Mrs. Thorat. And as Ravi said, thank you to the ICS for giving us this opportunity. I'll take off from where Ravi left about how COVID, in addition to providing challenges, has also given us opportunities. And to me, I'm an eternal optimist, and I think we've had a lot of learning from COVID that we will carry forward for the future, which will stand us in good stead even after COVID disappears from the world. And I'm especially, one of the smaller things that I'm thankful to COVID for is the opportunity to be part of this and to speak after two absolute legends, two people whom I've admired for the last 20 plus years, who are on the top of the cancer care scenario in the country. And probably, but for a twist of fate, I might have at some point been working along with them, which I will consider my loss not to have done so. I think Usha put it well when she said a lot of it is based on predictions as to when it will, when the COVID pandemic will end. And here I must confess that after reading a lot about several of the models that we've heard from various experts, I think everybody's just guessing about what the trajectory of this pandemic is going to be. We have predictions ranging from it's going to disappear in a few days to something that will last at least till the end of the year and could come back in a second wave or a third wave subsequent as well. So I must say that any prediction that I might make is hazardous and should be taken with a pinch of salt. I think Dr. Shanta mentioned that several of the consequences of COVID-19 have been experienced by most cancer centers. And these have been multifold. They have included challenges for patients, shortage of hospital personnel, and I think this is a consistent theme across hospitals. Even in a fairly large government hospital like ours, we did feel the pinch of a shortage of hospital personnel, primarily because many of them, as the disease progressed, had to be quarantined. Many of them were high risk and therefore had to be kept off the front line. The lockdown had its own implications as far as challenges to reach the hospital were concerned. Practically every hospital in the country and probably globally have had a shortage of supplies, whether it be masks, whether it be PPEs and N95s. There's also been a shortage of beds and ventilators. But perhaps what has been singular in the way we've responded to this pandemic has been the almost complete fear and panic, both amongst the general public, amongst the patients and healthcare workers. And I find here that amongst these three categories of people, the general public, patients, and the healthcare workers, at least for cancer care, we found that cancer patients were the least fearsome of COVID-19 because they were more fearful of the implications of being delayed, of getting delayed or being denied appropriate cancer care. So we were left with this fairly tight balancing act that we had to do, which was the need to continue cancer treatment for our patients, fully cognizant of the fact that any delays would be quite potentially disastrous as far as cancer outcomes were concerned, and with the fact that we also needed to ensure that our patients and our employees remained as safe as possible. And sometimes these do happen at cross purposes to each other. So it's this constant struggle and tension that we've had to manage, that the decisions we make on a given day might be right for that particular day, may not be right, and it could completely get overturned within a very short time. And we needed to be extremely nimble and flexible in the way we make these decisions. So how do we prepare? I think this is not extremely detailed. I think we need to understand that we need to stick to the basics, and then elaborate on what I mean by that a bit later. The single most important thing that I would emphasize much more than any other aspect of my discussion today would be that we need to protect the vulnerable. And I'll again elaborate on that a little later into my talk. The strategy that we need to isolate, and this has been spoken of widely amongst infectious disease experts. Most importantly, we need to continue to share data and experiences. And I think several of the publications that we've had, which have needed to be retracted, come from this reluctance to share data. And journals as big as the Lancet and the NEJ have had to retract data publications because of the lack of transparency and the ability to, or the willingness to share data between researchers. There are some promising approaches. I will not dwell too much into them because they're all, as of now, merely conjecture. So we'll go by what I would call as very principles, the general principles, which are reduce the risk to the patient, reduce the level of healthcare resource utilization to fit the amount of resources that we currently have, identification of suspected cases, create a larger R0 and reducing the risk to the healthcare workers. And these may not always work in the same direction. So coming back to what are the basics? This comes to simple measures like hand hygiene, physical distancing, and cough etiquette, all of which are established infection control measures. But when you actually look at something which is as elementary as this, and the fact that many of us fail to follow this, it's truly tragic, because they have been responsible for several of the staff getting quarantined, as well as several of our other patients and other staff getting infected as well. And the principles are again extremely basic. That's why I said these are basic principles which we need to stick to, rather than look for very fancy solutions to what is effectively, hopefully, a transient problem. I think Dr. Shanta and Ravi already mentioned about their own strategies for avoiding overcrowding. And I think we followed a very similar strategy at the Tata Memorial. We rescheduled follow-ups using teleconsults, limiting the number of visits. And I think these are, again, lessons that we learned for the future as well. We do a lot of things by sheer habit. And what we've realized and what COVID has taught us is that not all of them might necessarily be required even after we move out of this pandemic as well. Again, coming back to the basics, this is something that's probably true for every single hospital. Screening at the entrance for symptoms of COVID and making sure that we avoid transmitting the virus from a patient or a staff member. And the important thing to remember here is that very frequently staff as a potential source of spreading the infection is often ignored. So we follow exactly the same screening that we follow for patients for our employees as well. And all of us, starting from the director right down to the labor staff, go through a screening for these symptoms, as well as a thermal screening prior to their entering the hospital. We use the same kind of strategies which were described earlier, redirecting patients to avoid mixing with the rest, avoiding crowding by calling only relatives for medicine refills or arranging home delivery of medicines, telephonic follow-up for compliance, and to ensure that we reduce the number of footfalls at the hospital, rapid consults in the outpatient area, and so on. So what did I mean by saying we need to protect the vulnerable? I think we need to accept the fact that a large number of us will get infected in the very near future. The rate at which the virus is spreading, it's inevitable that many of us will get infected. What is important is that the morbidity and the mortality in the young and the not so vulnerable is extremely low. So by being at the front lines of treatment or whether of front lines of routine life, the young and the not vulnerable are the ones who are best able to take it. So if you look at this study done in New York, where they had the maximum number of infections, what seems very clear is that as age advances, your potential to develop critical consequences or complications of the COVID infection also increase. More than 60% of critical infections happened over the age of 60, and more than 80% happened over the age of 50. So what is clear here is that we need to be able to protect the elderly. What is also clear here is that those with comorbidities, and if you see the median number of comorbidities in the New York study was 2, which means that if you are able to people with uncontrolled hypertension, uncontrolled diabetes, cardiac disease, kidney disease, and smokers away from conventionally considered high-risk areas, we will be able to reduce the morbidity and mortality out of this pandemic to a large extent. This translates directly into the way we deploy our staff. So one of the first measures that we took at the Tata Memorial was to identify those who were at risk. So out of a total of 3,000 employees that we had, we laid off or we gave paid leave to 262 at the initial response, as soon as the pandemic started in India. And we gave them completely fully paid leave and gave them opportunities to work from home, so that those who were vulnerable, and by this I mean those women who are pregnant, those who were post-transplant and on immunosuppressants, those who had uncontrolled diabetes and hypertension, were spared from frontline duties, and thereby protecting the vulnerable from developing the complications of COVID. Which meant that the remaining staff had to do a lot of multitasking. And the fact that, as Dr. Shanta mentioned, the week on, week off strategy, which most hospitals to offer multitask, and it was often a very familiar sight to see top consultants of the hospital coming out to regulate crowds, to clear the cleaning the operation theaters. So it's been a great equalizing experience, and it completely brings to forth the dignity of labor. And I think it's broken down hierarchies to a large extent at our own hospital. It also meant that we had to train a lot of our staff on infection control measures, the appropriate use of masks, gloves, and PPEs, and most importantly, doffing strategies, as well as waste disposal as well. So what we did was to break it up into much smaller groups. We have a very large employee organization, so we had to break it down into multiple smaller groups, a systematic process of train the trainers, wherein smaller groups were trained and each of them started training multiple others. And this snowballing effect has hopefully translated into a much better infection prevention and control measures being done at the hospital. I'm not going to dwell too much into what we decided about cancer care during the pandemic. And this probably needs to be individualized per institution. So I don't think one institution may not necessarily work in another. But the basic principles on which we decided was that we needed to decide what stage of the pandemic we are in and what's the likely trajectory. And this is where we are as likely to be wrong as we are to be right. And it's in predicting what the trajectory is that decides what our strategy should be as well. So we made sure that these were disseminated in the form of National Cancer Grid guidelines for delivery of cancer care. These are by no means extremely detailed or elaborate, but we felt that these were important measures to share. And I'll urge each of you to go through this very small but very paper which came out in Nature Reviews Clinical Oncology about 6 weeks back, which strategizes and prioritizes the kind of treatment that we need to give, giving the least priority to those where the impact of treatment is not so high, and the highest priority where the imminent risk of early mortality and if care is denied, the consequences of that are likely to be much higher. And these are often very difficult decisions clinically that we need to make. As physicians, as caregivers, we are all trained to provide, try to provide the best possible treatment for our patients. And often this is not possible when you're faced with a pandemic like this. Then we need to make some triaging decisions as to, given the resources that are available, what would you prioritize above another? So we came out with these set of guidelines. We had separate sets of guidelines for surgery, for radiation, how to prioritize radiation therapy, how to prioritize chemotherapy. And again, these meant that a lot of very tough decisions needed to be taken. And we shared these as part of our own response, which we hoped would be a learning process for several others as well. So what can hospitals do now? And I'll use the Tata Memorial response as a kind of a template. And I wouldn't for by any stretch of imagination suggest that this is the only way of doing this, but we found that this has been extremely helpful as we went through this the last few months. And I suspect that this will be the same kind of strategy that we'll adopt over the next few months as well as we navigate our way through these quite difficult times. So the single important thing that I would suggest as a very crucial part of how we have managed the situation is open, transparent communication with our employees. What we need to get is the complete buy-in from our staff. And this doesn't happen unless we are clear to the employees, to our staff, that we've been open and transparent. So with every single decision that we took at the hospital, this was immediately conveyed by a variety of methods. It happened through WhatsApp, by Telegram, by phone calls to heads of departments, to face-to-face meetings with small groups of people. Even the first case that we had, the first patient who turned positive, I still remember the time and the night. It was around 2 o'clock at night when we got the first positive case being diagnosed at our hospital. And we spent the next 7 hours informing our staff about it, letting them know about this event, so that they were very clear that if whatever happened at the hospital would be immediately conveyed to them. And I think this has been key in getting their faith and trust in the way we took decisions. As I mentioned, we made sure that our high-risk employees were provided fully paid leave, thereby keeping them off the front line of patient care and protecting them from possible complications of COVID. As Dr. Shanta mentioned, we used the staff sparing strategy, week on, week off, the patient-directed initiatives, which both Dr. Shanta and Ravi mentioned. So these are some of the pictures that we had. These are all attempts to reduce the crowds within the hospital. Those of whatever required could be done outside the hospital was shifted outside the hospital, within the compound, but outside the hospital building, so that we could reduce crowds. A lot of it involved hospital preparedness, and we had to suddenly come up with a lot of SOPs for COVID-19 related activities. For a pure cancer hospital to even imagine creating a fever clinic within hours, convert a cancer ward into an isolation ward, to quickly put together a COVID-19 testing facility. We've never tested for COVID-19 ever prior to setting this lab up. We set it up in a record time of 72 hours, which meant getting different departments, putting their equipment, their manpower together to be able to get an ICMR accredited testing facility within 72 hours. And to me, this is key to handling the pandemic well. Unless you can test, trace, and isolate, I don't think we are doing a great job in handling the pandemic. Compounded to this was the problem of the national lockdown and having to create facilities where staff could get transport to the hospital. And I'll show this in a small video in the next slide. We suddenly had to cope with a situation where patients couldn't get transport, patients couldn't get food. Though food for inpatients provided by the hospital, the relatives are not usually provided food. Suddenly we had to double our capacity.
Ramesh sir, we are not able to hear you, sir.
Are you able to hear me now?
Yes, sir, much better.
Yeah, sorry. So it's also meant that we suddenly had to increase the capacity of our kitchen to have to provide food for our patients as well as their relatives. So usually food is provided routinely for our patients only. So suddenly with the lack of restaurants, hotels, and other places where relatives could get food, we had to practically double the capacity of of our kitchen to be able to make sure that the relatives got food as well. And often this happens over weekends where the ability to scale up staff is limited. So a lot of our staff come from places which are very far, and most of you are familiar with the city of Mumbai, know how much we rely on the local trains. And suddenly when the local trains stopped, we realized that we had to come up with solutions to sort them out. So we had to create this bunch of buses. So we suddenly had to hire buses which could transport our staff. And within a period of a week, we've realized that the initial 12 buses that we hired, each producing 3 trips, were still not adequate to cater to the demands of our staff, the needs for our staff to reach the hospital. So we scaled this up day after day, and currently we run 22 buses, each running 3 trips, a total of 66 trips, bringing our staff from different parts of the city to the hospitals to make sure that we had the critical number of employees to run the hospital with. We also had to deal with supply chain disruptions, not only the non-availability of PPEs, masks, and N95s. The last mile transport always got to be a bit of a challenge. Couriers were unable to shift the material from the courier godown or where they stocked it to the hospital. So we had to deploy our own hospital vehicles to do that. What we had to learn quickly was to be able to share the data so that we start doing research and try and find solutions to the unique problem that we are facing in. We had to make very quick decisions on participating in clinical trials, ethics committees having to meet virtually as opposed to the traditional way of meeting. And we finally realized that the learning that we had needed to be disseminated to the National Cancer Grid and beyond. And we did this through a series of webinars. We've done 9 so far. We've got the 10th one tomorrow. And we were blessed to have some of the top speakers in the world being part of this. We had speakers from the WHO. We had speakers from the CDC in the US. I mean, practically the who's who of infection prevention and control, as well as pandemic management. And Professor Vijayaraghavan, Gagandeep Khang, Clifford Lane is the second in command to Anthony Fauci, who's leading the US response to the pandemic. So we've had varied speakers coming in on all of these. And we also realized the key role that our less acknowledged staff play. So we had webinars devoted to nurses, which were directed primarily for nurses' approach to infection prevention. And we again published this recently in the New England Journal. So I come back to this and how do we prepare? And I think I've addressed the top 4 points quite well. What is promising and I hope will change the way we manage this pandemic is our 2 very promising approaches. And I call them promising because we don't have data on them yet. And I'm hopeful that the coming weeks will hopefully come up with some solutions which will work. The first of them is antibody testing and the immunopass. It's a very controversial topic, but something which is being debated in several countries. The philosophy being that if you develop immunity and that is measured by measuring neutralizing antibodies in your blood, and if you have developed antibodies because of a prior infection, you are safe, and the likelihood of your developing COVID-19 again in the near future is limited, and therefore they could be, these staff could then be at the front line of taking care of COVID patients. The second part, which is not likely to be that earlier solution, is the vaccines. To me, this seems the more promising long-term solution to this, because I don't think this is going to end with just one wave. We are likely to come up with subsequent waves. And hopefully by the time that happens, we will have vaccines which are working. Let me come back to a few points and to how practically at a ground level we can actually prepare. I think one thing we've learned out of this is that we need to be prepared to spend a lot of time planning. On an average day, we spend between an hour to an hour and a half just strategizing on the next day. And we've done this day after day for the last 3 months. Every single day, the core group meets for an hour to an hour and a half just to learn from the mistakes we made in the past and how we could improve on things in the future. And I think this is time well spent. As I mentioned, maintaining employee communication is crucial. I think that's something that we've learned to do pretty well over the last 2.5 months. It's a series of emails, WhatsApp messages, videos being circulated across employee groups to make sure that they understand why the decisions, what the decisions we take and why we take them. The other thing I've learned is also that we need to be ready to change decisions very quickly. And this is often difficult for leaders because we make decisions based on data, and to be proven wrong is not very palatable, but it's important that as soon as you realize that a decision that you've taken is wrong, we need to be ready to change this very quickly, failing which the consequences can be quite dramatic. This is easier said than done. We need to try to be one step ahead of the virus. But having said that, be prepared to fail most times. But because you fail most times doesn't still absolve us of the attempt to try to be one step ahead. And I think, again, trying to think for the future, trying to think a week, 2 weeks, 3 weeks into the future is extremely important to be able to try and manage the consequences of this. But to me, I will stop with this single most important prayer. And this is something which I think both Dr. Shanta as well as Ravi emphasized. Pray that you're blessed with dedicated staff. And I think from what I've heard from both Dr. Shanta and Ravi, we've been extremely blessed that we've had the staff that we work with and to enjoy the kind of trust that we have with them. Thank you very much for your attention, and happy to take any questions.
Then this is indeed a tremendous, huge initiative. I would like actually now to just one question that Jyotsna has asked. Jyotsna, will you like to ask your question yourself? She'll have to be unmuted, yeah.
All right, can you hear me now?
Yes.
Now my question is for the screening centers that we run. Our center is open, but we have not yet had any clients coming in. But I wanted to know, what are any special precautions that we should take? And what any difference in the procedures that we have followed all these years?
Dr. Pramesh, would you like to take a go?
Sure. I think whether it's a screening area or a screening station or the hospital, or to me, even in general life, the one thing that we need to keep remembering is that every person that you meet is a potential COVID patient. And we need to take utmost precautions to ensure that we don't contract it. Or I'll take it one step further to even consider ourselves as an asymptomatic COVID patient so that we don't transmit it to others as well. So again, stick to the basics. universal masking, make it mandatory that whoever you meet is wearing an appropriate mask. We take appropriate precautions with hand hygiene. We limit the duration of interaction to the bare minimum, and certainly not more than 15 minutes, if at all that's possible, and maintain an adequate distance of preferably 6 feet, but if that is not possible, 3 feet. And in several clinical situations, this is not always possible, which is why I suggested that we limit the duration of this contact to the bare minimum. And with these precautions, I don't think there is a necessity now to limit our screening or our treatment or our routine life activities either.
Is it safe to do an ENT screening?
Yes, a lot of our screening, especially for oral cancer, does involve examination of the oral cavity, and this is an aerosol, potentially aerosol producing procedure, which makes it a high-risk procedure. But provided that we are adequately masked, we wear the right equipment, and maintain universal precautions, I don't think this is a necessarily something that needs to be avoided. For those who are routinely performing aerosol generating procedures, I would strongly recommend an N95 mask and not just a surgical mask, because
Yes.
that provides additional protection over just a cloth mask or a surgical mask.
Thank you. Thank you.
Thank you. Thank you very much. Could I now request Dr. Titus, who's just come back from Bangladesh, to maybe share with us, because he's come back so recently and he was there during this period, to just share with us how they have been dealing with it. Is there anything we can learn from them? Dr. Titus?
I think most of the things that have already been, can you hear me?
Yes, thank you. We can hear you.
Yeah. So most of the things that are happening in Bangladesh are very similar to what has already been described by the previous speakers. And I think the first reaction by most healthcare workers right up front was fear, and not knowing whether they themselves would contract the disease. I know of several colleagues who decided that they were not. It took a lot of persuasion for it to be threatened. That was interesting. The other thing was the information from various sources. Decided that maybe the hospitals were the worst places to be in if you were sick, because that's where you could contract the disease from somebody else who has COVID and who comes to the hospital. And so they decided to stay away. So many of our patients who actually needed treatment early decided, that they would stay away. So the most important thing that happened during the first month was to educate both patients as well as the healthcare staff that there were ways to, have this interaction between the patient and the healthcare staff without necessarily each of them being too much increased risk. Other than that, dealt with COVID exactly like what our hospitals here are dealing with. One of the things that, new things that was started in the hospital that I worked with was, say, an e-pharmacy service. They started delivering drugs to patients at their own homes, and also, an a blood taking service. So a home blood taking service. So patients, got their bloods taken at their own home. So somebody went there and did a venipuncture. And that was, these were interesting things that were, and so having an internet connection was a very important thing at this time.
Yeah, I can very well.
I myself was in, having come back, I had to be in quarantine for.
We are not
Can
able.
you hear me? Hello?
Yeah, there is some break in your connectivity now also, I think. So Are you able to hear us?
Yeah, I can hear you.
Okay, so
Hello.
you were saying something, doctor?
Can you hear me?
Maybe we'll come
Yeah,
back
no,
to you.
I was saying that telemedicine was.
Dr. Titus, I think we'll just come back to you. Maybe it'll improve by then. May I ask Dr. Kantaria, who's here, I believe, from Koraj Hospital. Is Dr. Kantaria here? Vinisha, can you identify him and unmute him, please? Dr. Chaku, we'll just get back to you because I think your connectivity. Tushar, is he there?
I don't think so, ma'am.
Okay, okay. Dr. Shanta, one question that has been asked
Hello.
is, yes, hello?
Hello.
Yes, who's that? Can you identify yourself, please?
Good evening, madam. This is Dr. Kantaria.
Okay, yes, please.
Hello.
Yeah, we can hear you. So we'll
Oh.
just, you have to show yourself on the video. I think you have to unmute.
Yes. Good evening. Yes.
Yeah, would you like to share your experiences?
Hello.
Vinisha, he's being shown as muted.
Hello.
We can hear you. Please carry on. Please carry on speaking. I think then the video may come.
Yes.
Do carry on what you were trying to.
Yeah. As good evening, all.
Good evening.
Yes, we also went through, and gone through the whole process, and the way operated. We also had the same thing at our hospital. Taking universal precautions, going ahead, with our routine OPD, and we started our surgical work from April, say 15th of April. But we made a point, and we got approval from a state health department for a COVID test. Way we're doing, and during this period of 7 days, we saw and we got 25 during the period. So, yes, but surgical and the volume
I think,
came down to
Doctor, your voice is breaking. We are not able to hear you very clearly. Maybe
Yes.
the internet is not very clear, or I know how unreliable it can be.
I am audible.
You're audible, but you keep breaking. Your voice keeps breaking in between.
Yeah, it keeps on breaking. Yes.
Can I just ask a question which has been raised? As Dr.
Yes.
Shanta and Dr. Kannan particularly, this is for you. When you test for COVID and you find the patient is COVID positive, then the cancer treatment takes place in the hospital, or you have to send them elsewhere?
What we have done,
Dr. Shanta.
what we have done is, because Chennai is a very high risk area, patients coming from home every day back and forth, the propensity to get the infection is much greater. We advise them to be hospitalized. But the problem in hospitalization, we do not permit any attendant, and as you know, Indians want a lot of the relatives with them, so there is a little problem, but people are accepting. So we prefer to have them in the hospital at least till the whole the corona problem reduces a little in Chennai.
Okay. Kannan? Ravi? Yeah, you have to unmute yourself. Or you've been muted by the... Vinisha, please, can you unmute Dr. Kannan? Yeah.
So, since the number of patients in the region is not very high, we are still following the old ICMR rules for testing. Somebody has contact, history of travel, set of standard symptoms. Only those people who are suspected to be potentially positive are tested right now. Medical College, which is a testing center, also uses the same rules. Everybody else goes through cancer treatment as planned. The only patient with cancer, actually there were two patients with cancer, one with a gallbladder cancer and one with a chronic lymphocytic leukemia. The individual with the lymphocytic leukemia stopped his treatment for the duration. His viral test was positive, and then he's restarted now. The other individual with the gallbladder cancer had a very advanced cancer. He was essentially for palliative care. And so most patients are actually not being tested. They're going ahead with treatment because there is no history suggestive of infection. This is okay, I think, because the number of patients in the region is very low at the moment.
Dr. Chacko, how do you handle this? How do you do it in CMC? Are you testing, and then how do you handle with the COVID patients who are cancer patients?
So they are admitted to a special ward, where there are only COVID positive patients and single rooms, and then they are administered whatever necessary treatment that they need in those separate wards. So we're basically isolating them from everywhere else and protecting them and other patients and other doctors from being in contact with them. So those who go into these wards are with full personal protective equipment, etc. But they get whatever treatment is required.
Okay. I believe, Homi, were you wanting to make some comments and suggestions? Did you ask for that? Will you?
Yeah, I'm with it. Yeah. Usha, I was looking at it in two compartments, really. One is the processes and procedures which specialized hospitals are following today. And obviously, we've learned a lot from the way our doctors, Pramesh, Dr. Shanta, Dr. Kannan, they've handled this particular crisis. And it's a tremendous learning experience for all of us because it's, an untested area and the terrific work they're doing in those areas. But I think the other bucket of things which worries me is the issue which Dr. Shanta mentioned, and that is survival of the hospital financially during this crisis. And I think that from whatever interactions I've had with government people, they seem blissfully unaware of the plight of the hospital sector today. They seem to think that with great initiatives like Ayushman Yojana, the country's medical problems are all going to be solved. So what are you guys talking about? But they don't realize the actual crisis which is facing hospitals today for want of funds. You have no OPDs, you have no people are postponing their whatever surgeries they want to do, they postpone because they don't want to come to hospital at this stage. 80% of the beds, or even some of them 100% of the beds, COVID patients. So they don't have anywhere to go. And I think the government is not looking at it seriously enough. And I think something has to be done to make them aware of the need for at least sustenance and keep these hospitals alive. They can't afford to just say, they're doing great things for the future. Today, the need of the hour is to, take care of the hospitals which are looking after the health of the nation. If we of the nation. So some approach has to be made to Delhi at a high level, at the appropriate level, either with the health minister or jointly with the finance minister and the health minister. And Usha, you may know probably, what is the best contact and who to use. But I think something has to be done to make them aware of the crisis that hospitals are going through today.
I think, Homi, that's a very, very important point. I'm sure Dr. Shanta, she mentioned right at the beginning, this is going to be a major problem. And I think maybe on, all the hospitals that are, amongst our empaneled hospitals, they could be a joint kind of a, submission. But mostly the response will be, this is a matter for the state governments to do, that may be but then I think it's worthwhile taking it up because seriously, this is not only a problem which is having for, what shall we say, not only for cancer patients. I think Dr. Shanta wants to say something. Yes, Dr. Shanta.
I think it is the COVID, what it has done is it has highlighted its importance, and the other areas, other diseases have gone into a shadow. Now, unfortunately, cancer is as big a problem. People did not understand it, and I think cancer is not getting the adequate response in terms of taking care as other diseases. Of course, COVID is very different. We have to take care of it, but we cannot leave cancer alone. Cancer is a major problem, and I think people dying of cancer is not to be allowed, because we do have sufficient technology and knowledge to take care. We were coming to a phase when we are able to cure cancers, large number of them, a few were not. So the institutions that are giving the treatment have to be supported in whatever way possible. But I think generally the government's health policy has to be revised.
Thank you. I know Dr. Gauri Kapoor had also wanted to say something. If she's still there, maybe we can get her queries or views. Dr. Gauri Kapoor from RGCI Delhi. Are you there still? Or maybe you've left, I don't know. So maybe we've really overshot our time and many people might have left. But I just, I did have some, is there anyone else who wants to sort of raise any issues right now? I just thought I would just share. I mean, I did have a screen to share, but
I think Dr. Shanta wants to say something.
Usha, can I?
Who's that? Purna, is it? Who's that?
Yeah, Purna.
Yeah, Purna has to be unmuted.
Can you hear me?
Yeah, but there's some sound.
1 minute, I will.
In the meantime, I think Dr. Shanta wants to say something. Dr. Shanta?
I think she said the government's policy needs to be revised. That is her final comments on that. And I think it's
Am I audible?
Yes. Yes.
I think there is enough money.
Am I audible, Usha?
I think it has to be distributed correctly and to the correct people. I think that is important. It is not happening, especially in the health sector.
Yeah. Yes, I think Dr. Purna Kurkure.
It is something like, should I continue?
I think just 1 second, Dr. Purna Kurkure wants to make a point. He's also associated with a hospital in Mumbai. Yeah.
More than COVID and experience of the people during this period, I would like to highlight how we have in Cancer Cure Fund, we have been able to, or what we have faced while we get the applications. That is also equally important. Is here, he can share his experience at the level of due diligence as to what we faced and what modification we made in our operational, means our processes to facilitate granting of the funds even during this period. Tushar, are you there?
Yeah. Ma'am, so I will let Dr. Shanta say the very important thing which she was saying, and then in the end, if Usha ma'am permits, ma'am, you can show the last 2 slides and that will explain everything.
Yes.
Shanta, your advice first.
Yes, Dr. Shanta.
Now the state insurance scheme is there for cancer. It is with a lot of deficiencies and obstacles. Nothing really moves fast. Now, similarly, the Bharat, something else has been given for 5 lakhs. It has not come to Chennai at all. I think the implementation takes a long time before it comes. The CMCH gives 2 lakhs for treatment of cancer. It is impossible to treat a patient fully, a complete curative case. 2 lakhs is very inadequate. even if you want to do it at the minimum. I think we at the institute take care that we do not overspend. But even there, I think it is very difficult, and it therefore creates lot of unnecessary I mean, say, and I don't want to call it unethical issues. I do not want to discuss it in the open.
Thank you, Dr. Shanta. Maybe Tushar, if you can just give a brief of how we have been doing it, and in the meantime, if Anne, you can just upload those last 2 slides. Tushar can just get on with it, and you can then
Sure,
share the screen which I had originally in my presentation.
Right. So, ma'am, it's been a lesson of, I have taken down notes of all that I have learned during this last 1.5 hours from the doings of oncology and dealing with COVID during the situation. I think what Indian Cancer Society Cancer Cure Fund has done is we have tried to be there for whatever applications have come in. We have tried to expedite the applications, and again, we have used technology to our benefit, and it has also taught us that many things which we thought were necessary are actually redundant, like a lot of paperwork, a lot of unnecessary meetings. A lot of things could be done online, which we did online. And if Anne can share this screen, I would like to show that in the last 3 months itself, even after the lockdown, we have been able to process more than 450 cases and sanction up to 10 crores of rupees. So I think that speaks for itself. Ma'am, you can take over.
Okay. Basically, what this shows, and just before this, Anne, can you just show the previous 2 screens? Because in any case, I think one would like to see that. Okay, now this just gives our trajectory of the applications and sanctions over the period since we started the Cancer Cure Fund. We did have a very increasing rate, and the maximum number of applications were sanctioned in the year 2017-18, which slowed down in 2018-19 and 19-20 because we did have a lot of disbursals out of the earlier committed cases. So we had to manage the sanctions, and now we were hoping to go back into the full blast of the sanctions, especially as we did get some new committed funds. So the next slide, which shows that over the years, clearly, then this is what Hari was saying about increasing it from 3 crores to 30 crores. And we were pushing to an annual spend of 50 crores. And in the process, we were also trying to see whether we could improve our, economize or optimize the time of our oncologists. And as a part of that, we have started simultaneously to look at an AI application, which is being developed by Navya, which is a Bangalore-based organization, which the Tata Memorial Hospital is also using. And theirs is a second opinion sort of a service, but we were using it to see whether we could actually put the primary scrutiny of applications from the hospitals through them so that we can deal with a large number of cases. So from a monthly of something like 215, 220, 240 per month, and we were hoping to go to 300 or 400 per month, we have come down, as you see, in the period March, April, May, and June. So while this has declined, the fact remains that we have dealt with these applications. We have dealt with these applications without actually by working from home. We have done amazing work the Cancer Cure Fund team has been doing to see that the entire lot of applications are put in a manner that the due diligence team, wherever they are, could have a look at them and take a view on them. And then the Governing Advisory Council, which has been meeting virtually and sanctioning. Tushar has been presenting cases where we discuss in detail and cases where we can clear. And this has been possible, like Tushar said, we have done it without, I mean, it was quite an elaborate earlier, but now we have been able to do it. And I think we've now kind of stabilized. So the short point of what I'm trying to say is you please send as many applications as you can. We will be able to support them, and we will make sure that it's turned around in the shortest possible time. Where there are emergencies, we will do it even in a double fast time. We do not have to necessarily wait for the GAC to meet. We can easily do it. We have a protocol for doing it. And I think that can be done once the DDT has approved it. So I think we are here, but actually the way that I'm looking at it, I find the hurdles for the hospitals are quite a lot, not only in terms of sending the applications to the Cancer Cure Fund, it's also much more in terms of the overall hospital financial positions as well. So where we are today and where we want to go next, and so this is what we've done. We've kind of scaling up. We're optimizing the time of oncologists. The web-based uploading of applications is still not there, but we do manage to. I mean, it is web. It's scanned and sent, but we want to make it much more on a process-driven basis. Our dearest wish is to expand the empaneled hospitals to the underserved areas of the country, and because the unique aspect of the Cancer Cure Fund is we want to bring affordable quality care nearer to the homes of the patients, thereby reducing their overall burden. And finally, we want to maximize the value, and this is something, again, works in progress with the national guidelines of the NCG and the Ayushman Bharat. We have over big thanks to, like Hari was explaining, the HDFC AMC, which has supported us in this endeavor, the BPCL, State Bank of India Foundation, and the Aditya Birla Capital. These have been some of the large donors, but there have been a number of other smaller donors whom we can't individually thank, but we are extremely grateful to them. I think this today's webinar has been really a unique experience. The one thing that really is coming home to me is, and I think it's not only true of cancer hospitals, but like Dr. Shanta says, the delay in treatment or not treating cancer when you have the ability to do so is really a matter of survival. So it's equally important to save cancer patients' life as it is to saves lives for people who are, contracting COVID. So this whole, I thought that Dr. Pramesh's balancing act and even the subsequent one was so well placed, and I mean, very, very apt. And I think that is where the cancer hospitals, I would say all hospitals, but cancer hospitals certainly do need to be given a separate support. Now, where these funds are going to come from, whether this is going to come from the central government or the state government, or whether we're going to be able to get more donors, because our appeal to donors also meets the same answer. Right now, our funds, our CSR is going towards COVID. But I think there has to be a reality check, and we have to realize that if we are going to live with this COVID, and as Dr. Pramesh said, it's very uncertain, then we have to realize that we have to deal with cancer as well. And a very good question Dr. Jyotsna raised, that means do we all stop our screening protocol, because a big activity of a cancer NGO is screening. And I think that's extremely important as well, because we know cancer detected early is totally curable at a much lower cost. So these are matters we cannot postpone. They have to be dealt here and today. And that, I think, message is not actually coming through. I don't know whether you'd agree, Dr. Pramesh, and you have a much more reach, and Dr. Shanta is, I'm sure, agrees. I mean, I really don't know. You can guide us how would this message has to be taken forward. It's not something that is I think, coming through. Do you want to have the last word?
So I think there has been growing awareness about the fact that, especially for diseases like cancer, it shouldn't stop for the sake of COVID. And I think after that initial panic set in, where hospitals and caregivers started having a knee-jerk reaction and avoiding it, I think most hospitals and healthcare providers have come across to the situation that we need to continue providing cancer care. So I think that's likely to be less of an issue as time progresses, and at least personally, I'm quite optimistic that there will not be too much of delay in providing care.
But what about the funding and the financial issues? Because that seems to be crippling.
That's true. That's true. I think it's a chicken or the egg phenomenon. Till the patients start coming into hospitals, the hospitals don't generate enough income to be able to run it. So which comes first is the question. And looking at the slow increase in volumes that we've been seeing over the last week or two at our own hospital, I'm fairly optimistic that as the travel restrictions ease out, we'll continue to get more and more patients.
Yes, Dr. Shanta wants to say something.
Screening, we say. How are we going to do the screening with maintaining social distance. Number one. Number two, I think you will have to put a stop or uh, just as they have done on laboratory testing, the price of each. The cancer treatment given outside by many corporates, the cost is something phenomenal. I think that is controlled. The other things there will be money enough to take care of the underprivileged.
Thank you. Ravi, you wanted to say something?
Yeah, I think just as Pramesh mentioned, we're all getting used to the initial spike of fear is slowly ebbing away. And so the same thing with as patients start coming in, everything we have to go through this in order to be able to rationalize and say, okay, we can go on. Everything will, this is going to be with us forever or for a long time. And so, money also will slowly come around. This acute phase shortage that is happening will not be forever. The next 2-3 months, I think this will even out. We just have to wait it through.
For me, that's an optimistic note to end on. I think I think that is an optimism we have to hold on to. And like you said, the biggest things that we realized throughout the period of COVID that it's optimism, it's a positive outlook, it's working together, it is that humanity in us. That is what is really going to take us out of this period. And we can all be optimistic with people like you at the empaneled hospitals and all over the country. I certainly feel that, yes, we have to be optimistic. Thank you very much.
I want to go on record, Usha, to say that we are going to have a V-shaped recovery, not a U-shape, not W-shape, but a V-shaped recovery. As all the doctors
That's victory. Yeah. So thank you all very much. Thank you for being here. We've had about 2 hours already. And I think it's been a great sharing of experiences and learning from each other. Thank you all so much.
Thank you, everybody.
Thank you so much.
Thank you. Thank you very much.
Thank you, Usha. Thank you.
Thanks.
Thank you, Usha, for organizing this.
Thank you. Thank you. Dr. Shanta, நீங்க பூரா 2 மணி நேரம் உட்கார்ந்திருக்கேன் அப்படி பாருங்க. ஒரே எனக்கு
I'm waiting. I'm not sure it is over.
I'm really impressed at the way you've sat through for 2 hours. Really amazing. I don't know what we would be doing at your age. I have no idea.
I find it boring sitting doing nothing.
Oh my God.
For me, Shanta ma'am is a source of inspiration, great inspiration.
I was amazed at her voice. I mean, it's so strong. It's so powerful. Really. Namaskar.
I think we will come out of it.
Yeah,
I think we'll have to come out of it at some time. It will take time. And we are expecting it overnight. I think we are just now learning. I think we have to learn more.
Absolutely. And then people
will get less panicky and understand what is to be done. I think, but again, cancer patients have a lot of problem because when they come, we say no attendant, only one attendant, and that attendant has to be negative. I mean, all this adds to problems. So it becomes mandatory. I think once the things start going down, and as prediction, maybe June it will go down. We will see how it is end of June.
They're supposed to reach the peak in July.
I tell my people, we watch every month.
Yeah,
we watch every month.
Right. Thank you. Thank you very much.
Okay, thank you.
Thank you. Okay, Colonel, thank you so much for this.
Most welcome, ma'am. It was a wonderful session. I enjoyed every minute of it. And with all the stalwarts in the cancer space.
Thanks, Anne, for everything. Thanks, Tushar. I don't know whether he's there.
Managed it
Anne is
really well.
Vinisha, thank you, dear.
Vinisha, special thanks to Vinisha.
Let's see your face.
Yeah, we want to see who's Vinisha. Here she is.
Welcome, ma'am. Ma'am, should I end the meeting so that the recording gets converted?
Is there?
Is there? Yeah, do that.
Yeah, it'll take time. It'll take time for you to save the recording.
Yes, yes. So I'll end the meeting, ma'am.
Okay,
Yeah.
great.
Thank you.
Thank
Thank you,
you.
Usha
Thank
ma'am.
you all.
Thank you so much.
ma'am. Thank you.
Thank you all.
Bye.
That's my
Thank you.
thanks.
Bye.
Thank you,
Bye.
Dr.
Yeah,
Tushar.
thank you.
Thank you.
Bye.
The ever smiling face, Dr. Tushar.
We're all a smiling lot, I think.
Yes, yes, yes. Ever smiling.
Okay, bye.
Okay.
Bye. Bye.
Thank
Thank you, ma'am.
Bye.
Thank you.
Bye.
Good evening.